In the next part, we are going to show you what kind of signs can be seen on ECG when the patient does have ischemic heart diseases. The ECG sign, depending on the severity, uh, is varies. Let's see first how the normal situation occurs, how normally the myocardium depolarized and repolarized. Normally, the depolarization goes from the endocardium to the epicardium. This is why an electrode, which is watching on the surface of this depolarization, is going to give us a positive R wave. The repolarization normally started in the epicardium and goes to the endocardium. However, because the depolarization ended last in the epicardium, this is why the repolarization started a little bit slower and after speed up when we had in the endocardium the most time to synthesize ATP. So this is why if you're looking at the T wave is never symmetric. The first slope is less, while the final one is rapidly going back to the isoelectric line. What will happen when we do have a subendocardial ischemia? Every vessels, every coronaries is passing the myocardium from the epicardium to the endocardium. So the endocardial area is the most affected one of the less supplied with oxygen. During contraction, this supply, the blood supply or circulation in the endocardium is almost zero, and some oxygen can only transfer or diffuse from the chamber of the ventricle to these areas. Let's see what will happen during the depolarization. The depolarization is not altered in any kind of ischemia. It doesn't depend on energy. So we do have very similar R wave. Now, because the epicardium is not affected, this is why the repolarization starts from the epicardium slowly. However, it cannot be speed up in the endocardial area. So what will happen? The speed be about the same, so the T wave be symmetric. They had the same slope up and down. In a more severe condition, when we do have a subepicardial or transmural ischemia, basically, the epicardium or the whole muscle is affected, and the whole muscle has less oxygen, so they uh, do not have enough oxygen, enough efficiency to produce ATP. So needs a little bit more time. So what will happen? The depolarization works the same as before. However, the repolarization now is affected, and the repolarization is going to start whichever area we had the most time, we had the most chance to synthesize ATP. So it's starting from the endocardium and goes toward the epicardium. However, we do have a different charges. This is why now the T be inverted. So the ischemic sign on ECG involves the T wave, and it can be symmetric or can be negative, can be flat, can be biphasic. So the ischemic sign is manifest. In a case of injury, the ATP level is so low that the cell cannot maintain the normal membrane potential. This is why in this area where the cells are injured, more positive charge stays inside, so the resting potential is getting closer to the threshold. Outside the cells is getting more negative. So at rest, we do have a bipole that it will show or pointing at the normal cells. So this bipole is generating is called diastolic injury current. During the systole, when the cells depolarized, you can see nicely that in the lesion, less positive charge can flow into the cells comparing to the normal one. So we do have a systolic injury current as well that goes and influences the ST segment. When we look at the mildest form of the lesion that involve the endocardium, and it's called subendocardial lesion, what happens that this resting potential pointing toward the surface, toward the epicardium. So the absolute zero baseline is pushed up. So, and we are going to record a little bit more positive baseline. When the depolarization starts, we do have an additional pushing up current that goes and push up the tracing. However, when we depolarize the endocardium and the epicardium, so all has the same charge, there is no further charge differences. So we are falling back to the absolute zero baseline. During the depolarization, again, we are going to build up the diastolic injury current, and as you see here, this is manifested as an ST depression. So ST depression or subendocardial lesion, that means there's an angina. This is the picture of angina. When we do have a subepicardial or transmural lesion, this area involves the epicardium. So this diastolic current is pointing toward the endocardium. So the baseline is shifted down to the negative part. So the depolarization starts down because this current is going to push down. And when we depolarize everything, epicardium and endocardium, we getting back to the absolute zero baseline. And now the repolarization restores the original baseline, the false baseline, and that's manifested in ST elevation. Not every ST elevation or ST depression is pathological one. We do have a unit or a value for each lead. Generally, we can say that in limb leads, every ST elevation that is bigger than 1 millimeter is pathological, or in a chest lead, if it's more than 2 millimeters, it's pathological one. The ST depression is half. So in a limb lead, if we do have a half millimeters of ST depression, that's pathological one. Or in a chest lead, 1 millimeter is the pathological one. However, today's that's clinical studies shows that almost every lead they do have different measures for the pathological elevation or suppression. Plus, it's going to add necrosis. During necrosis, the cells that died completely inert. There is no electric activity. So what's going to happen? If you place an electrode over the necrotized area, everything is going to point away from this area. Looks like you're looking through the chamber through a window. So this is going to generate a negative wave as a Q wave. This is why the Q wave is so dedicated. In the opposite, as a mirror image, we do have a prominent R wave that represents the opposite side as a Q wave. Sometimes the necrosis is not involves the whole thickness of the heart. This is why we still have some tissue that can generate some depolarization wave. However, the R wave be less, so R reduction can be the sign of necrosis as well. This R reduction can be seen very nicely in V1 to V4, where we do have a normal R progression. Another thing, the pathological Q wave, it has a measures. It's wider than 0.03 seconds and deeper than 1/4 of the size of the R wave. Another thing, if the patient did have an ECG recording where they did not have any Q wave, and now that Q wave is there or deeper, and the patient has typical pain, you have to consider the patient has necrosis.